is the nuances of the S1 dorsal foramen. And this is from a study which was published from Elsevier. So S1 transforaminal epidural steroid injection is a very common procedure as most symptomatic lumbar disc herniations occur at the L4S5, L4L5 or the L5S1 disc levels. So a symptomatic S1 nerve can be accessed by an intraneural L5 approach and more reliably so via the S1 dorsal foramen. And in recent studies, the S1 dorsal foramen has been found to be accounting for around 30% of lumbar transforaminal epidural steroid injections. So access to the S1 dorsal foramen can in fact be very challenging due to the complex and the peculiar anatomy. And as such, it can be difficult to visualize fluoroscopically. And in these cases, ipsilateral oblique positioning can be used to bring the fluoroscopic view parallel to the S1 dorsal foramen and to properly visualize the foramen. And as such, the target point would be the apex of the dorsal foramen. And the authors of this study, they have advocated walking the needle into the foramen from its lateral aspect, primarily as a means of establishing the depth. So from this study, they have reported nuances of the S1 sacral segment, and they have specifically described a dorsal bony flange, which extends from the medial to lateral part and shields the medial aspect of the dorsal foramen. This flange actually is a very thin cortical bone, and hence it is very difficult to visualize on fluoroscopy. A down the beam trajectory of the needle to the central or medial of aspects of the S1 foramen as such might make the entry difficult. And it is this need to avoid this flange that obligates an ipsilateral oblique trajectory to enter the foramen and requires access from the lateral aspect of the foramen. So coming to the methods used in the study, the authors have provided a report which includes radiographic and fluoroscopic image correlations from an experienced clinicians who has performed S1 transforaminal injections over the years, and secondly from cadaveric anatomic observations, and thirdly from a series of pelvic CT reconstructions. And these have documented the imaging appearance of the flange and quantified the size of the S1 dorsal foramen in both the AP and ipsilateral oblique views. So coming to the anatomic specimens, 27 adult human specimens were studied. And for each specimen, firstly, the posterior layer of the thoracolumbar fascia was carefully reflected, and this revealed the underlying multifidus lumborum muscle. Subsequently, each multifidus was dissected away to expose the posterior sacroiliac and interosseous sacroiliac ligaments. These ligaments overlie each of the dorsal sacral foramina, thus leaving a very small opening for the sacral lateral branches to exit. Hence, after identification of the S1 dorsal foramina, the whole ligamentous complex which was overlying it was dissected away to the bone to identify the entirety of the foramina. Then each foramen was photographed and measured using a metric ruler, and the maximum vertical and transverse axes were measured in millimeter. In addition to that, the transverse length of the bony flange was measured from the medial margin of the foramen to its free edge. As we can see from this image, this is a posterior view of dissection of the right S1 dorsal foramen. Inside the white box, we can see the area where the S1 dorsal foramen lies, and this has been magnified in image B. And they have outlined the margins of the S1 foramen in blue and the flange in pink color. Hence, the transverse measurements of the foramen would be B, and the transverse measurement of the flange would be A, as depicted in this picture. So coming to the CT images, so they have used an institutional database which included 50 CT scans of the pelvis of patients which were aged from 23 to 90 years. And from the original axial images, they have done a 3D reconstruction or rendering, And from that, the dimensions of the S1 foramina were measured in vertical and transverse axis. Subsequently, the 3D model was rotated into an oblique position to maximize the opening of the foramen, and measurements were again taken in vertical and transverse dimensions, and the same procedure being repeated for the opposite side as well. So coming to the results of the study, the authors have characterized the S1 bony flange using correlative anatomy, cross-sectional as well as fluoroscopic images. As we can see in these images, this is the image of the dissection in the sagittal view. And in the black dot, we can see the location of the dorsal root ganglion, and overlying it, we can see the huge bony flange. And the same has been illustrated in this picture over here. This is the bony flange, which is encountered while trying to enter the foramen. Now, in the subsequent images, they have gone 9 mm lateral to the previous images, and as can be seen, the flange now uh, has been exposed as only a small chunk of bone overlying the foramen, and the same has been shown in image E, which is a photo of a dissected specimen and a lateral perspective image. It reveals the bony flange, which has been highlighted in the black arrows, and this covers the medial aspect of the S1 foramen over here. So coming to the correlative T1 weighted MRI images in the mid portion of the F1 foramen and the in F and in the lateral aspect in G. So we can see the huge flange over here and the underlying dorsal root ganglion. And in the lateral aspect, we can see the flange getting minimized. And in H, we can see the posterior view of the bony sacrum and the flange covering the medial aspect of the S1 foramen over here. So coming to the next set of fluoroscopic images, this is a setup for the left S1 dorsal foramen axis. In A, we can see that the S1 end plate is aligned to the beam, and we can see the S1 foramen faintly over here, which has been marked with a white arrow. So in the next image in B, they have gone for a 10 to 15 degree ipsilateral oblique view. And in this, we can see the foramen fairly better, which has been highlighted by the white arrows. And this, in fact, can be traced by the arcuate line of April, which extends from the medial margin of the S1 pedicle in continuity with the lateral margin of the S1 canal. And in C, we can see its anatomic correlate and the flange, which is present medially, which has been highlighted over the black with the black arrows. So in another patient, we can see over, in the next few images, they have shown a 25 gauge needle which has been inserted, and it contacts bone on the dorsal plate of the sacrum. And this is they have highlighted in black, what they have highlighted in black is the medial portion wherein lies the flange, and the needle has been inserted quite laterally. So in E, they have manipulated the needle further, and what they have shown in F, in image F, uh, is a lateral view in which the needle is inserted deep to the dorsal margin of the body of the sacrum in this direction. So, coming to the anatomic dissections, the dissections of the specimen revealed that the dorsal foramen was consistently found to be covered by a ligament which extended from the medially situated bony flange up to the dorsal plate at the lateral aspect of the foramen. Only when this ligament was removed would the bony margins of the flange and the relationship to the foraminal aperture would be revealed. So these are the dissected prone specimens. The black line over here indicates the midline, and in A we can see the dorsal foramen, which has been highlighted in white, and it is covered by a typical ligamentous covering over here. Coming over to the image B, the ligament has been removed by dissection, and we can see the foramen and the overlying bony flange over here, which has been shown by white pointed arrows. And in image C, it shows the PA view of another prone specimen where the photograph or the specimen has been rotated ipsilateral obliquely to highlight the foramen and the flange over here. Next, from the images, the dimensions of the dorsal S1 foramina were taken and which have been provided in this table, and there was found to be no laterality difference in the foraminal dimensions or flange length as in terms of the individual foramina on both sides of a single specimen. So here they have shown us the frequency distribution of the S1 flange length in millimeters in the cadaveric specimens, and they have found it mostly to be around 2 millimeters to around 4 millimeter. And from the statistical analysis, they have found that the mean flange length was approximately one third of the mean horizontal dimension in the foramen of the foramen. And in 14% of the cases, the flange nearly covered half of the horizontal width of the foramen. So coming to the CT images. So from the CT reconstructed images, they have taken the values for the dimension of the S1 foraminal aperture in both PA and oblique views and have seen that the dimensions range from 4 to 12 millimeter. And again, they have charted this and they have found in this frequency distribution table that the foraminal size in oblique view was in fact larger than that in the PA view. And subsequently, statistical analysis was done, which revealed a statistical difference which was significant in terms of foraminal size between the PA and oblique views. So coming to the 3D volume rendered images of the pelvis, we can see over in these images, in the PA projection, the dorsal S1 neural foramina opening is partly covered by the flange over here. And in the next image, in the ipsilateral oblique position, the trajectory has been created as such that this prevents the flange from blocking access to the foramen, and the foramen can be visualized better, as can be seen in image B. So in another patients, as can be seen in images C and F, which have been indicated in black arrow, uh, the flange largely covers the foraminal aperture here and here in these two images. So in the ipsilateral oblique position with the dorsal foramen placed tangentially cephalate to the ventral foramen, which have been shown in image D and in image G. So what they have shown is the foraminal aperture being accessible now when they have created an ipsilateral oblique direction and the caudal to cranial trajectory, the foramen can be better visualized over here and over here. So coming to the next set of images in ENH, what they have shown is the dorsal and ventral foramina would be superimposed whenever we make a more cranial to caudal angulation, and there would be no bony impediment to the needle passing into the pelvis. This can be seen in this image and image E. So, from these images, it was seen that the measurement of the transverse foraminal dimension was larger in the oblique position in 85% of the studied specimen and studied images, and it was unchanged between the PA and oblique position in 15% of the cases, and in none of the cases it was found to be larger in the PA position in any of the foramen. So coming to the discussion, as such, the existing primary text describe S1 axis through a cranio-caudal fluoroscopic angulation, and the dorsal and ventral foramina are described as potentially overlapping in this text. However, in this study, the authors have placed the dorsal foramen tangentially superior to the ventral foramen. As can be seen in these fluoroscopic images, in the unadjusted AP view, the dorsal and ventral foramina are partially superimposed over here, and placing the making the trajectory and making the X-ray beam ipsilateral oblique, as seen in this image. So they have placed it ipsilateral oblique in images B and C, and they have shown a listing snowman, and they have advocated a trajectory like the needle placed over here, and they have advocated this trajectory, and what they have advised and what they have found is that this will result in more cephaloid needle tip position and likely a better flow direction pattern. As can be seen in this image as well, a trajectory which is more cephaloid over here would minimize the risk of pelvic penetration and maximizes pelvic penetration, and this has been favored as per the author's clinical experience. So to conclude, access to the S1 dorsal foramen can be confounded by a dorsal bony flange, which extends from medial to lateral across the transverse dimensions of the foraminal aperture. As such, the aperture is also protected by a ligament which is rising from this flange. And as the flange can be poorly seen in fluoroscopy, it could be quite challenging for the operator and the pain physician to go ahead with the procedure. And as such, the authors have uh, prescribed an ipsilateral oblique trajectory to be utilized in this, and this would enhance the image and make the procedure easier for the pain clinician. So that is, thank you. Thank you so much.
Very well done, Dr. Kaushik. Actually, it was a
Uh,
complicated paper. He has made it really simplified. You can
so
share it.
am I audible?
Yes, yes, sir. Yes,
Yes,
sir,
sir.
you're audible.
So Kaushik, can you go to your last image, the slide that was showing the in fluoroscopy? These
Yes.
before that, yes.
Yes, sir.
So it has been seen that quite a few people they find it difficult to you know uh, do S1 uh, injections because the S1 foramen always the bone is coming, and the success rate of getting through S1 is comparatively low because this anatomy is very important. So if you see the first slide on the left side, and you see the disc of L5 vertebra, it is not properly squared. So in this, though you can see in AP the foramen, but the as Kaushik told, the anterior foramen is not overlapping with posterior foramen. The ventral foramen is not overlapping with the
Dorsal foramen. Yes.
foramen. You can't your needle will not go through S1, and there will be a problem. So there are two important steps. One, there first you have to scare the L5 disc. In the middle one you see the
Yes.
L5 lower end plate is scared. So by doing this, you are aligning the dorsal and ventral foramen. That has to be done. And once you do that, then you move your C-arm to ipsilateral, maybe 10 degree to 15 degree, whatever it may be. Then ultimately you will be finding that situation on the C side. This is number one. Unless until you do that, your foramens will not open, your flange will come into the way. And the last and important point that I want to highlight is see the point of the entry. It is just uh, below the pedicle of S1. So if you try to enter the foramen from the medial margin, probably you are hitting the flange again and again. So even though you see this foramen in ipsilateral and a cranial position, your point of entry should be on the just below the uh, pedicle of S1. Otherwise, you can see the tip of the needle, and the trajectory is hub is on the outside and the tip is on the medial side, and it is just on the outer edge of the foramen. So your trajectory has to be like this, and this is how you will find. So this is only I want to add, and it's a beautiful topic, one of the best topic for S1 foramen, and this is for everyone, very practical and uh, informative article. That's why we choose it for the day. Thank you. This is what I want to add from my experience, and I welcome comment from other person also.
Thank you, sir. Thank you, sir.
Thank you, sir.
Dr. Dhruv, do you have any additional comments or anything information
Yeah,
you would
so
like
I
to
think,
add?
good evening. So I think that
Yes.
it was a beautiful topic, and as I think Dr. Ashu also said, that it is something which we struggle for. One thing which I'll always say is that in these kind of situations where you are not sure about any intervention, uh, bone is your friend when we are doing it in under fluoroscopy. So you can directly go for the foramen also, but people who are just starting off, or in cases, what I sometimes also do is that sometimes we do not get these perfect images. In that scenario, bone becomes our friend. So once you get the foramen, try to hit the boundaries of the foramen and then gently tap it in so that there is no harm, because that will give you that surety that you are not deep in, your depth can also be controlled and you are sure that you are at the pedicle. So that would be one thing. Rest is, I think, one suggestion would have been like if they have put in the dye also. So that
Yes.
will also give us.
Yes. Because lot of time
No,
we
I have a lot of.
yeah.
I'm
Yeah.
outside. Otherwise, I don't know how to show it. I have a lot of images for dye, but I'm on
No, that is
mobile
fine,
phone.
sir. But only thing is ki
Yeah.
with regards
No,
to the article,
yeah, with regard to
Yes,
the
yes, yes.
article, if they could have
article
shown,
like
because lot of time we see AP and lateral is good, but dye
yes,
is not perfect. Yes, you're right.
yes. So the thing is that we always believe in the principle is wherever there is dye, there is going to be drug. So if as a matter of critical analysis of the article, they have not confirmed it with the, though anatomy, everything, dissections have been quite clear, but there has been no dye thing. So that is thing, but otherwise it's a good thing, and we all struggle. So that is one thing. And second thing is that sometimes what we do is the contralateral side also gives us an idea sometimes.
Hmm.
So that is, I think that
If you're
has
not
been
able to
picked up.
see the foramen, yes.
Hanji, Hanji. So that happens. I think that has been touched also in the initial introduction part, that these are the challenges and this is how we try to crack it. Otherwise, it's a nice article. Well presented.
Okay.
Yeah.
Thank you, sir.
Okay, Kaushik.
Just a small
Yes,
comment from me,
yes, Dr.
Dr. Achal, if you have your.
Please.
If you see this image, specifically the image C, so the direction of the needle, if you see, that is at the 9 o'clock position. Okay, if you just imagine the circle as a clock, the needle is entering at 9 o'clock position. What I usually do to rest of the thing is the same, that the C arm is placed in the craniocaudal direction so as to square the L5S1 disc. And when you enter, you don't, what I do is I don't enter from 9 o'clock position, I enter it from 7 o'clock position. And the needle is directed superiorly, so that ultimately the needle direction, if you see in the lateral view, will be pointing cranial, right? So that makes things much more easier. With little amount of dye, little volume of dye, you will see a good spread, even up to L5S1 disc or even going further top. So that is one thing. And secondly, in order to view the S1 foramen, the best thing would be to first localize the S1 pedicle. The one which is just below the foramen, that is the S1 foramen. Third thing is, if you encounter flange, the medial flange, the best way to disencounter is to make it more oblique so that your foramen, the dorsal foramen, touches the lateral part, the lateral edge of the dorsal foramen that touches the iliac crest. So once that is done, you got adequate amount of mouth of the S1 foramen. So then you got a better chances to enter the foramen. That makes things much more simpler. That's it. Yeah.
All right. Thank you, Dr. Ashish. So, so can you stop sharing, Dr. Kaushik, so we
Sure,
can
ma'am.
move to our next presentation? Actually, before moving to the next presentation, I have just 2-3 things to share. This is our, just a second. So this is our upcoming CME, which will show the live demonstration of MIPSIs there is a link. I have shared this flyer in Delhi and Gurgaon City Branch flyers. So if anyone is interested, you are more than welcome to register. And then we have made a special thing that this early bird, because of the lot of requests from the students in fellowship, we have the cost we have made till the a day before the procedures, before this actual workshop. We will just continue taking the amount of the early bird, so don't worry about the amount. And the second thing is, if somebody wants to hear to this conversation again, the YouTube channel, the question, the highlights you are getting from the thing, we have a YouTube channel, ISSP Gurugram City YouTube channel. You can go to that YouTube channel. In 2-3 days, I will always upload every journal club, and in the description, I always share the paper. And if somebody wants to be a speaker in this journal club, everyone is more than welcome to. I'm sharing my phone number. You can personally message me and let me know if someone wants to be speaker, someone wants to present anything specifically through this learning process. And for even participating in this live demonstration of procedures of the MIPSIs, which we will be doing, you can just WhatsApp me. So without delay, we will proceed to our next presentation. And it is the interesting case which the authors have shared doing the same S1 nerve block. We studied anatomy, and let's see actually what challenges one author faced, and he published the paper about it. Dr. Manoj, can you share your presentation?
Thank you. I'm not able to share.
Go to share. Are you not able to share? I'm making you host so that you can probably now you're able to share.
Okay.
See if you see share screen, share that the lower bottom column.
Yes, ma'am. I'm doing that. Now, are you able to see my slides, ma'am?
Yes, we are able to see your slide. You can just turn on the slideshow. Just give yourself a little introduction.
Yes,
and then you can start the presentation.
First of all, I want to thank ISSP Gurgaon for giving me this opportunity to talk on this wonderful topic. And I wanted to thank Dr. Ashu Jain, Dr. Dhruv and Dr. Achal ma'am for giving me this opportunity.
You have to be little louder, Dr. Manoj.
Okay.
Little louder.
I am having viral, so
sorry for that, but be little louder.
Okay, ma'am. I will try. I am consultant pain and palliative care department in Venkateshwar Hospital, Dwarka. And I am also having my own clinic with the name of Solace Pain and Spine Management Center in Sector 39, Gurgaon. And today I will talk about this topic, that technical challenges of performing S1 root block and what are the roles of double needle and multi-level needle techniques, which was published in British Journal of Pain in 2021 by Sanjeeva Gupta and al. And today's presentation moderator is Dr. Achal ma'am, who is senior consultant and head of the department in pain medicine department in BLK Max. Radicular pain in lower limb.
People are mentioning, come a bit closer. They can't hear you.
Okay.
Move your laptop a little closer.
Okay.
Or and be a bit louder.
Okay, ma'am. Radicular pain in lower limbs is commonly due to inflammation or compression of L5 or S1 root And this occurs usually S1 nerve root compression is usually occurs at L5 S1 disc level, center level, or in the lateral recess level. S1 root block is common intervention to alleviate the pain. The S1 nerve root exists through the S1 sacral foramen, and it supplies the sensory and motor functions to the lower limb. Compression or inflammation leads to the symptoms such as sciatica, weakness, or sensory deficits. Indications for S1 root block are when there is unresponsive to conservative treatment and patient is having severe radicular pain, and there is confirmed nerve root compression at L5 S1 level in MRI, and for doing diagnostic and therapeutic intervention for S1 related pain. This procedure usually performed under fluoroscopic or ultrasound guidance. Usually a 22 gauge or 23 gauge spinal needle is placed near the S1 root, and to confirm the needle tip position, we give contrast before giving the drug. Common challenges encountered during the S1 root block are anterior or posterior contrast spread, vascular uptake of contrast, and needle repositioning difficulties. And it has been found in various studies that the incidence usually varies between 10.4 to 27.8% of vascular uptake. And according to Salvian et al., under fluoroscopic guidance, S1 transforamen injection has the highest incidence of 19.9% compared to L5, that is 6.9%, L4 is 9%, and L3 is 12.5%. Then they advise about the strategies to overcome these challenges are adjust the needle placement by withdrawing or advancing by a few millimeter if there is a contrast spread issue. If there is chances of vascular uptake, confirm position before injecting any medications, and always use aspiration before giving contrast. And real-time fluoroscopy and or digital subtraction angiography also reduces the risk of intravascular injection. And they have, in this study, they have given one case study about a 39-year-old male who had neuropathic pain symptoms in left S1 distribution since 9 months. And on examination, patient had positive straight leg raising sign at 30 degrees. And there was absent left ankle reflex. And there was hyposthesia in the left S1 distribution. Patient was prescribed amitriptyline, gabapentin, paracetamol, and non-steroidal anti-inflammatory drugs for conservative treatment. But patient was not getting relief. So the decision was, and then the decision was taken to do MRI. And in MRI finding, as you can see, this is T2 weighted image is axial scan at L5S1 disc level, and this is T1 weighted image at the L5S1 disc level. So as we can see, according to MSU classification, this is Michigan's State University classification for disc herniation. It is 2AB because disc herniation is moderate and it is compressing in the central and paracentral subarticular region, which is lateral recess, and also in the T1 weighted images. And these MRI findings match the patient symptoms. So decision was taken to give the S1 root block in this patient because patient was having a persistent neuropathic pain despite conservative treatment, and left S1 root block was planned under fluoroscopic guidance. Written informed consent about the procedure was taken, and patient was explained about the procedure. Patient was taken into the angiographic chute, and under all aseptic condition, after giving local anesthetic, on the desired side, 22 gauge curved tip spinal needle was introduced by using subpedicular approach by the left S1 foramen. And then after reaching the position on lateral and AP view, a contrast Omnipac 240 was given under continuous fluoroscopy to rule out any vascular spread or incidental finding. So then the X-ray was taken after giving the contrast. In A and B X-ray view, you can see the contrast is not going to L5S1 disc level, which was our desired side, and the contrast is going anteriorly and posteriorly, but not going the S1 canal. But then the multiple attempts were done. Needle was positioned in and out, but desired contrast spread was not getting. So they came to the idea that we have to put second needle medial and infrared to the first. And in the C picture, you can see the contrast is going up to the L5S1 disc level, which was our target area. So then the drug was given, that is local anesthetic and steroid, after confirming the needle position. And the patient was followed up at 4 weeks. And patient reported more than 80% pain relief. And his activity was also increased. And the spinal surgeon consultation was also taken, and who also advised about the continuing the conservative management. So then common issues encountered during the S1 root block challenges are poor visibility of posterior sacral foramen and the anterior contrast spread, and there is high incidence of intravascular uptake. Then technical consideration we can do to overcome these challenges are to Scotty dog approach reduces the vascular uptake risk, and medial half placement of the needle reduces the complications in the lateral. And they came with the this flow chart that if the needle is in the middle half of S1 foramen, and if we found out in the contrast spread there is vascular uptake or anterior spread of the contrast, we can move needle pull or go in more in within few millimeters. And if there is still vascular uptake or anterior or posterior contrast spread, then we can consider for L5S1 infraneural or retrodiscal technique. Or if that is not possible because of the lumbar spondylosis or spondylolisthesis, we can introduce a second needle at the S1 level, medially or inferiorly. They have came to the alternative approaches, the idea that is multi-level needle technique by placing the second needle at L5S1 infraneural or retrodiscal level, or other techniques using like caudal epidural steroid injection, intralaminar epidural steroid injection, or epidural catheter placement through the caudal epidural position, and going up to the L5S1 disc level. Then the importance of consent and planning. MRI should be reviewed with the radiologist before the procedure, and we have to identify the anatomical challenges like tarlocyst, if there is foraminal stenosis, or patient having spondylosis. And written informed consent should be taken with flexibility in technique based on the procedural challenges. And we have to write that if this thing is not possible with the S1 foramen, we can go for the alternative techniques like L5S1 infraneural approach, or using the second needle in the consent itself. Then the key takeaways from this study was double needle technique or multi-needle techniques can improve the outcome, and recognizing the challenges early helps in modifying the approach. Careful MRI and fluoroscopic interpretation is essential, and proper written informed consent prevents the legal issue and improves the patient understanding. So this was this one S1 root block was done by me 2 days back, and as you can see, my needle is in S1 foramen, and drug is going up to the L4, even up to the L4 or L5 disc. And in the lateral view, our contrast should go in the S1 canal also, like going up. So this is, and thank you.
Thank you, Dr. Manoj. Dr. Dhruv, sir, if there is any extra info, additional or comments you would want to add or ask any questions.
No, ma'am, thank you. I think Dr. Ashish has a question, but this is something new for even for me, that the manipulation part is something that we are actually doing. Even sometimes I have gone for caudal if I felt that I am not getting a good spread, or somehow I'm not convinced so fully. So that is one thing. What we have done is we have used sometimes a catheter also through the caudal route, just to be sure that we get it there. But two needles are something that
It's a
is something I would
new
like to
thing.
try, let's
Yeah.
say.
Yes. People are
Right.
using 2 needles like in trigeminal. Dr. Ashish, I'm sure, would be keen
I
to
think he
add
uses a
because
lot
he
of 2
does that
needles.
2 needle. Ashish,
Yeah,
sir,
yeah.
please.
Yeah, Dr. Ashish.
Actually, wherever the foramen allows you to put 2 needles, you can definitely put in 2 needles. That is what I believe. That is how I put in 2 needles for trigeminals also. But let us just restrict our talk to this. So basically, what I wanted Dr. Manoj to show was the first slide. I find it very surprising that in the lateral view, the needle is not visualized, or am I missing it? Yeah.
Yes.
In the lateral view, is there any needle visible? I can't see the needle there.
Yes, sir. I am also not able to
That's
see.
a good catch.
Uh,
That's a very good
See,
catch,
because
actually.
I also not see.
what I think is
Probably they would have
basically
taken
what
out the
had
needly hole and
exactly. So I do not have any idea where if the needle was, see, if it is going from dorsal to ventral foramen and you inject the dye, it is definitely going to go give you that type of
Obviously.
image, right? And then there is no point in putting in 2 needles and justifying what you have done. What you should have done is you should have taken the needle out and then you should have placed the needle in such a way that it should have pointed caudocranial. Then the dye would have gone to the cranial side rather than going to the ventral side. Okay, so to be very honest,
I
I don't
also not
and
seen, sir,
see
this
and
type
and
of
and one
contrast
more
spread
thing
in S1 foramen.
and one more thing, you see the image A. Look at
Yes.
the direction of the needle.
Yeah,
You can
again, it's
very
not
easily see
pointing
that it is
lateral.
going from
Yes,
cranial to caudal, right?
yes.
It is going from cranial to caudal. So if you imagine in the lateral view, it is definitely going from the dorsal foramen to the ventral foramen, the needle. So ultimately, when you inject the dye, it is going to go in that direction and it's going to come out through the ventral foramen, right? So I don't find the credibility of this report to be very, very authentic, to be very honest. But then definitely, 2 needle technique is not a bad option. You can definitely, and if you see the direction of needle 1 and direction of needle 2 in this C image, needle 1 is coming from cranial going to caudal, whereas needle 2 is just bang on, end on. So in lateral view, you would find that the needle is pointing more cranially vis-a-vis needle 1. If you can just imagine the three in the
And
three
they have not
dimension.
made it ipsilateral. If you see image C, it's just AP. I mean, if you
Yeah,
see the
it's
sinus
AP. But what
process,
I'm
then
saying is,
Hmm.
what I'm saying is, had they taken a lateral view of the C
Hmm.
image, it would have made things very, very clear.
Yes, where the
Needle 1
needles
would have been
actually
seen
going.
from going
Yes.
from dorsal to ventral foramen, and needle 2 would have been seen to go from the caudal to the cranial direction.
Yes.
So this is what I caught
I think we should write letter to
when I
editor
was seeing
with
this.
all these flaws in this paper.
Yeah, because see, they're technically trying to make a point just to prove a point.
Yes, exactly. So it is just a justification of the. So when you have publications like this, you lose the credibility of the journal as well.
As a whole,
So
yes.
the editor also must make it a point to catch all these things.
No, I also
That
agree.
is the only.
This is a foolish article. By any means, you see the position of the needle, the how they have exposed S1, and this is a well-known fact that S1 is the most vascular foramen among all these. And most of the time, you manipulate the needle slightly cranially, caudally, or slightly deeper or superficial, and you are able to get through. So there is no the direction of the needle is absolutely funny, and it's a useless article. And I think we must write a letter to the editor regarding such articles. Not a good
What you're
technique.
saying is very right. But then it is something which the beginners should definitely be aware of, because I think anybody who has done an S1 root block would have definitely seen the dye go ventrally.
Yes.
So
And
they should know as to why it is going ventrally.
If your depth is too much on lateral, it will go ventrally only. Na? So
Yeah, exactly.
on lateral,
So the newcomer should know
you
as to
have
why
to
the
see.
dye is going ventrally.
Yes.
Yes.
So in the lateral, before injecting the dye, your tip of the needle should be in the canal, na, rather than in front of the foramen. So
One more thing. I would suggest is that because when you are putting in the dye, put a little amount of dye, because you otherwise the anatomy goes for a toss.
Yes.
So just a little bit, so that you just get an idea whether you are in or out. Because even if you see in the A image, the dye is so much that it is very difficult to imagine where the foramen is going to be. So if you are not sure, try to minimize the amount of dye that you are putting in. Otherwise, it becomes very difficult to
No, but
visualize, and then वो फिर मतलब you just keep doing the guessing game, or you put saline to wash it off, and then it becomes a
no,
Second,
mess.
doing the procedure second time becomes extremely difficult.
Yes, ma'am.
no,
Because
but
anyway it's very small. I think the first article beautifully
ऐसे
talked
ही
about,
बहुत
and if you
मुश्किल
put
से
in,
दिखता है,
yes,
right,
हाँ,
right,
तो फिर
right.
उसमें डाई ज्यादा डाल देंगे तो पूरा काला हो जाता है फिर,
और
तो दिक्कत।
दूसरी बात ये पक्का है बिगिनर्स के लिए, आप पहले S1 कर रहे हो तो लेटरल व्यू में देखो कि इट इज ऑलवेज ए चांस यू कैन कम ahead of the foramen ventral
Yes.
foramen.
100%, sir.
So
Yeah.
there is no point in injecting dye. Your tip of the needle has to be in the canal before you do that. So
Sir,
roughly that is in the middle of the ventral and dorsal border of the sacrum. So
definitely, sir.
without that, how can you inject dye? So this man might have injected dye. They have not shown the depth. It is definitely not in place. So it's a useless article actually.
One more thing, in continuity, I would want to point out, Dr. Manoj, whenever you are taking an image of the dye, I mean with the dye, it is always better that you take a scout film without the dye first, and then when you put the dye, then things will be much more easier, like what you showed in your last image. No, if you can just show me your last image, I'll just point it out again. The Siam view, yes. So here, what you have done is you have shown the AP image in which your dye is seen to go cranially. Same thing you can do with the lateral view also. In the lateral view, just take a scout film without the dye, put in the dye, then take a image again.
The tip of
So
the
that
needle
will
is
make
visualized.
everything much more brighter.
Yes,
Yeah.
sir. In
So you
lateral
can
view
make a
also dye is
comparison
there.
between the two. You can make a comparison. That is what I'm just trying to make things more presentable that way. Okay. Otherwise, nicely presented.
Yes,
Good
both of
article.
the
Worth a lot of
yes,
discussion. Yes.
yes, yes. I'm sure a lot of people who are listening must have learned a lot, because this is actually a challenging block to do. Not
Yes.
like a very straightforward like S1, L4, sorry, L5, L4. So again, thank you, Dr. Dhruv, for joining, Dr.
Thank you
Ashish,
so
sorry,
much, ma'am.
Dr. Ashish, for
Thank you
your
so much.
valuable comments. And I again, invite all of the people who are listening to, if they want to be a presenter in our journal club. Our next journal club will be on the third Friday of April, 18th April. And our workshop CME, which is coming. Please, you are more than welcome to join. I've shared my number in chats. You can directly DM me. And if you want to listen to this conversation again, then it'll be available on our YouTube channel. So thank you all, and good night, everyone.
Thank you. Thank you. Good night.